Thank you for downloading Children's Pedcast, a conversation about pediatrics with children's hospitals and clinics of Minnesota. My name is Jimmy Bellamy, and this week my guest is Dr. Meysam Kebriaei, a pediatric neurosurgeon here at Children's Minnesota, and we talk about neurosurgery, epilepsy, seizures, advancements in the treatment of epilepsy, hydrocephalus, and we also talk about genetics, something near and dear to Dr. Kebriaei's heart, 22q, the deletion syndrome. We will learn more about that as well and why it's important to him. You can find us on Twitter at Children'sMN, find us on the web at childrensmn.org, and you can find us just about everywhere podcasts can be heard: iTunes, Stitcher, Spreaker, Podbean. Enjoy this episode about neurosurgery with Dr. Meysam Kebriaei. Was this a passion you had growing up, or what led you down this career path?
Well, I've always been interested in becoming a doctor. You know, I shadowed doctors in high school and in college and medical school. I really enjoyed surgery and really enjoyed working with the neurosurgeons when I rotated with them in medical school. And so I really enjoyed it quite a bit. Time would just fly by, and I wouldn't feel fatigued and just would want more. And so I wouldn't say it was a passion for me from the beginning, but it became one as I got to know what neurosurgery entails and what how we interact with our patients and the rewards and from it.
How do you view what we are able to do today compared to, say, a decade, 2 decades ago or beyond, and then what is on the horizon in 5-10 years?
I think it's a really exciting time to be a neurosurgeon. We have so many innovative techniques to treat what were classical diseases that we would have to do larger craniotomies for, maximally invasive surgery with long recoveries, potentially big risks as well, that now we're doing with lasers, where we at Children's have a laser interstitial thermotherapy where we can treat a tumor or epilepsy and have it be an overnight hospital stay. I think we're going to be even, a lot further ahead in 5 years and 10 years. And so it's very, very exciting.
Before laser surgery became a possibility, it was craniotomies that were the procedure of choice, and that had a significant recovery time.
Well, that's exactly right. So the options were, one, it was a craniotomy, and sometimes they were, billed as they were called inoperable tumors, where you really couldn't operate on them because the risks were so much higher than the benefits you would get from going in and operating. And now, one, if they're inoperable, that is no longer a term with as much with a laser interstitial thermotherapy as an option. And also the big craniotomies now don't have to be. Again, there's still a lot of situations where we still have to do a craniotomy and with very good outcomes, of course, but a lot of those have been replaced by more minimally invasive procedures like the laser interstitial thermotherapy.
What does that do for you in this field, knowing that there are more things now that we can do for patients rather than saying inoperable?
Well, I mean, it's it makes me feel a lot better. One, as a neurosurgeon, when it's really a tough situation to be in, to tell a family that, a brain tumor or a disease is inoperable. That's basically saying that there's not really a treatment option for it that we can treat right now. And so, one, it's very, very nice to be able to treat the disease process, and two, to take away a lot of the risk associated with the craniotomy and have it be a much quicker recovery to get the patient and the patient's family back to their normal life is really great.
What are the areas within neurosurgery that you do most of the time? Is it the treatment of brain tumors? Is it finding ways to help somebody live with epilepsy or eliminate epilepsy? Is that even a possibility of being epilepsy free, or is it being to a point of health where you're seizure free and living with epilepsy?
Well, actually both. One thing that I love about my job in pediatric neurosurgery is that you can do the whole gamut of neurosurgery. So you're not forced to do just one area or one procedure. And also that's one of the things that we try to do as pediatric neurosurgeons at Children's, is that we try to focus on being able to each of us being able to treat all of the pediatric neurosurgical diseases that we encounter. And so, but a big part of my practice is epilepsy surgery, and we certainly have wonderful outcomes, and there are a lot of patients who would have 50, 60 seizures a day, and after a surgery, and of course we have a big team with neurologists, neuroradiologists, neuropsychologists, and social workers and nurses that help us. But after a procedure, that the patients would go on to be seizure-free completely, so their epilepsy would be treated, or they would have a reduction in the number of the seizures depending on what their pathology was to begin with.
It seems like it's longitudinal care as far as a treatment is given, a surgery is provided or received, I should say, by a patient, and then you're looking over a period of months, years, how is this changing? How is this improving? Is it difficult to have that wait and see approach rather than you had this procedure, we know you're good to go? Does it add anything, I guess, to your stress levels, knowing that this patient we are going to be following for a long period of time to see how he or she reacts?
Sure, I think that's a great question. The stress is always there because you want to have the best outcomes for these children that we see, and unfortunately sometimes even with medication and with surgery they still go on to have seizures. But a lot of times one of the nice things is you do get that you do see right away if they have improvement in seizures in the days immediately following the surgery, and of course then you're going to see them for months and years after surgery to see how they do. So that is a little bit stressful and nerve-wracking, but it's manageable.
Yeah, and I suppose it comes with the territory as well.
Right.
That's no surprise to you.
The upside of that is when when I'm in clinic and I have a patient that is 2, 3, 4 years out of surgery and they haven't had a seizure, and you talk to them, you just seen them, they've taken off because now their brain has all this free time to not seize and not have to recover from seizing, to learn new information, and that child is playing and growing and in school learning, and their families are so happy and they can do what other kids can do before they had the surgery. So that's really nice to see, and you also become a part of their family and they part of yours too, which is wonderful.
It is hopeful that you can have something that's manageable, or at least not nearly as daunting as it once seemed. Right.
That's exactly right. I mean, with one, there are newer medications on the market that work great to reduce epilepsy with decreased side effects. And again, if the patients are refractory to medication, then there are quite a few surgical options that we have out here. And at Children's, one of the things that we what we have, like, there's a laser interstitial thermotherapy, like we talked about, and we do all of the more classic treatments, craniotomies for epilepsy as well. But there's a RNS, which is an implant that can pick up where the epileptic zone is and stop a seizure before it happens. And that's a more novel method of treating epilepsy, but with very exciting results as well.
Epilepsy is fairly common as far as being known. There's common knowledge about epilepsy. We hear about it and we've heard about it for years. Tell me about hydrocephalus. What is hydrocephalus, if you can compare it to epilepsy, and is there any overlap?
So hydrocephalus is basically when you have increased fluid in the brain. We all have 4 normal fluid spaces called ventricles in the brain, and we make about half a liter of cerebrospinal fluid a day in those fluid spaces. And so hydrocephalus can be a combination or a result of one of the two things. Of one, you overproduce cerebrospinal fluid, or 2, and this is more common, you're not draining it as easily. So you're making all this fluid, but you're not draining it, and so that the fluid spaces of ventricles expand and put pressure on the brain, and that causes and that's what results in hydrocephalus.
Is that something that is discovered at birth, or is it something that's found over time in a child?
In both. Some of the patients that we see, the hydrocephalus has been diagnosed on prenatal ultrasound, and so even before birth, and we confirm it with clinical exam once the baby is born, and MRI, CAT scan, or ultrasound at birth. And other times we see it discovered later on in life. A lot of times in infants we see it when their head circumference is jumping percentiles, when they go in and see the primary care physician, and the physician notices that the head circumference is increasing a lot more rapidly than it should, And so that makes us suspicious for some sort of pathology like hydrocephalus.
What are some of the ways that we treat hydrocephalus?
Well, classically, hydrocephalus there's a surgical intervention for it. It's surgically treated. You can treat it with medication, but not for long term. And so one of the classical means that we treated hydrocephalus was ventricular peritoneal shunt placement. And that's where we put a small catheter into the fluid space, hook it up to a pressurized valve, and then connect it to another catheter that goes into the belly and gets reabsorbed there. And hydrocephalus like epilepsy, is a lifelong disorder. So it's not something that will go away or that you grow out of usually. And so the shunt, it stays there forever. It's a permanent object that we place. There are some newer, more novel treatments for hydrocephalus. For infants, we've started doing endoscopic third ventriculostomy, which is basically making a small opening in the floor of the third ventricle, and also coagulating the aquarial plexus, and that's what makes the cerebrospinal fluid. And so you decrease production of cerebrospinal fluid and treat the hydrocephalus that way as well.
What has it been like for you in working with kids and families compared to how a hospital that just treats adults or treats adults in addition to children would operate?
Well, I feel it's very important to, if we're going to treat children, to have a children's hospital, children's only hospital. And if we're going to treat adults, we have a separate adult hospital. I don't think you can overlap those. They're not little adults. They're children. They're a complete separate entity than adults with their own social needs, psychological needs, and physiologic needs. And so I love being part of children's here, in that we provide that care in all three of those facets.
We know that birth to 3 is crucial for the human brain. Are there procedures that differ in children from 3 years and younger compared to kids who are older?
Absolutely. And that's one of the fascinating things about children, is that they're at different ages, they're completely different, both, again, physiologically and psychologically. And so the different procedures are tailored for children of different ages.
When it comes to seizures, you had mentioned earlier about a procedure that can prevent the seizure from happening. Is that permanent, or is that something that needs to be revisited in a year, in 5 years, or any of these repeat procedures, I guess?
So it's permanent, but the generator, the pulse generator, is implanted, and it runs off a battery. So every few years, every 4 or 5 years, that battery has to be replaced. But it's not as big a surgery as the first time putting it in.
Mm-hmm. Okay. And when it comes to surgery itself, I know from shadowing Dr. Petronio when I started here, these can be rather lengthy procedures. How do you prepare for that? Is it something that's learned, or do you have the ability to keep that focus and work those necessary continuous hours in really high pressure situations?
Well, it's very similar to being a marathon runner. You can't just go into it having never done a surgery and stand there for 12, 14 hours and give it your best. As far as it's very draining, both mentally, emotionally, and physically as well. And so we have as pediatric neurosurgeons, very rigorous training. We have typically, after 4 years of medical school, there's about 7 years of residency training and 1 to 2 years of fellowship training. And so a lot of the training is very rigorous, and you spend a lot of grueling hours operating and being in the hospital and treating patients. So you do get used to it, so that you have that training also. And to be honest with you, during surgery, your mind is so focused that you're a machine, if you will. And so after the surgery is done, you might walk off to the locker room and realize, boy, my knee's really hurting, or I'm really sore from standing here for 10 hours. But during it, you really don't feel anything. You're just kind of, it's equivalent to a runner's high, if you will.
I can imagine whether it is adrenaline or something else that is allowing you to not feel those things. Are there any other activities? Is there anything else to compare it to?
I think each surgeon that you talk to would probably give you a different answer on what they do to sort of be fit for surgery. I try to work out on a regular basis, and I would tell you that most surgeons do try to be fit. I run when I can, and so physical preparation is one means of it. I make sure I eat 3 meals. I make sure I eat before my surgery, so I don't run out of energy. I think that's very important as well. And I think the most important thing is the emotional state. Mm-hmm. So I try to have a very positive attitude on life, and I've got a very supportive wife and very supportive children and friends and family. I think that helps me a lot.
I can imagine there's nothing that you can allow to be present while you're focusing on these surgeries, just because there are so many elements that go into that work that need to be on point in order to have a successful surgery. And you hear it all the time when people have surgery. They say, "Oh, it was a successful surgery," and unfortunately, that's what we hear. It's not the opposite.
Right.
When you're working in that environment, both in the moment and then also whether it's looking back on a procedure and looking ahead to future procedures, how much collaboration takes place? Are there times where you'll say, I think this might be the direction to go? Is there any of that, or does it require a lot of clearance where you say, this is what I think we should do?
We as pediatric neurosurgeons, we've all had enough training and experience to make the right decision, but no disease process is the same. So even hydrocephalus, epilepsy, they can present the same way, but they're not. The surgery is not going to be exactly the same. So we tailor our surgical treatment to that patient. And so if it's very straightforward, if you can call a neurosurgery straightforward, then you just go with a common treatment that's tried and true in the literature and in one's experience. But certainly there's a lot of collaboration. And I think it differs in different groups. But at Children's, we were lucky to have, for epilepsy surgeries, we have no less than 20 or 30 people that come to our weekly meetings where we discuss our patients. So we literally have input from everyone on our team, including our nurses, including our social workers that know the families and the family situation, to neuroradiologists, neurosurgeons, neurologists. And we all put our minds together and collaborate and come up with what we think is best for that family in that situation. Same with patients with brain tumors. We have neuro-oncology conferences where it's neurosurgeons, neurologists, radiation oncologists, and neuroradiologists, and we come up with a multidisciplinary plan for that patient. And again, what we think is best, and go with our recommendation there. And frankly, just in the neurosurgery community, it's a small world, if you can imagine. Mm-hmm. And so if there is a surgery or a problem that seems very complex, we discuss with our colleagues here. And you can post some of these online it's a very, information is protected. No information about the patient is given, and you have neurosurgeons internationally and nationally give you their opinions and sort of data for what they recommend, which I think is wonderful.
How about your recommendations to a family that may be facing a potential neurosurgery for their child? What would some of your recommendations be for preparing for that?
Medicine has changed in the last 10 to 20 years, and I'm on the, I did my training about 11 years ago, started my training in neurosurgery 11 years ago, and this is my third year in practice. So seeing how medicine has changed, it used to be very paternalistic in that you said, this is what we're going to do, and you didn't really have to talk to families very much. And now the expectation, and I feel like our duty as physicians is to explain everything to the family, from preoperative, what they need to do preoperatively, what's going to happen in surgery, what all the risks are, even if they're small, and the postoperative course period. So we spend a lot of time with the family, with the families of the children that we operate on, and explaining why we recommend what we do. We review the films with them. We go over the different treatment options, and is that a lot of times in neurosurgery, there's not one correct way to treat a neurosurgical problem, and so we go over the options and why we recommend the option that we recommend. And then we go over all the potential risks and benefits of the procedure and the recovery period. So
I wanted to ask you as well about something close to your heart, talking about genetics, 22q. Tell me about 22q. It's something people may have heard in passing, but for the layperson, what is 22q?
22q is a chromosomal deletion syndrome, and it has different names. So 22q11 deletion syndrome, and it got that name because that's the portion of the chromosome that's deleted, partially deleted. Velocardiofacial syndrome, and that name is more common in Minnesota and sort of the Midwest region, and that's sort of, that name is after the more common areas of the body that are affected. And DeGeorge syndrome, and DeGeorge is Dr. DeGeorge who basically discovered this syndrome, and so it's the second most common chromosomal abnormality after trisomy 21, and about 1 in 3,000 kids are affected. And this is close to my heart because my wife and I have 3 wonderful children, and our daughter, who just turned 4 yesterday, she was diagnosed with 22q11 syndrome when she was about 6 months old. It's very common, and unfortunately it's not as well known as trisomy 21 or other chromosomal deletions. And so it's very important to me that parents and physicians and healthcare workers are familiar with 22q, and so they can make the diagnosis. Unfortunately, there's not a treatment for 22q syndrome, but the treatment is supportive. About 180 different systems can be affected, and children can be affected differently. And so one of the more common things is children with 22q can have heart defects. So a lot of times when they're born, they have to undergo large cardiac procedures. My daughter has some heart defects, but she didn't need surgery for that, but she's got some other issues that we deal with. And so the earlier you make the diagnosis, the earlier you can sort of know what to expect and treat the organ systems that are affected.
Is there then regular checkups for any, in this case, heart defects that you would look at a year from now, 2 years from now, to make sure that she's where she needs to be?
There is, and it's a lifelong disease, unfortunately, and it's so from the time of diagnosis to throughout the patient's lives, they're going to be followed. They should be followed with kind of a multidisciplinary team, if you will, with Children's has a 22q clinic here where we or the other patients with 22q come for the day. You stay in one room, and all the specialists come and check on things and order tests that need to be ordered or follow up on tests, and so that's been a wonderful resource to have.
Tell us a little about your daughter, 4 years old. I've seen the pictures. We'll talk about the annual event. She's adorable. So tell us a little about her.
So her name is Roya. She's turned 4 yesterday. The reason that I'll give you the long version, but the way we noticed something was wrong with Roya was that she was 6 months old and not rolling front to back or back to front or sitting up, and she did have an older sister that was doing all those things, and so we found that a little bit odd, and she just seemed a little more floppy than my wife is a pediatric dentist as well, and so then the kids that we see on a day-to-day basis, and then her older sister. So we went and saw a wonderful neurologist, and he ordered a karyotype, which looks at your chromosomes, and so we discovered that Roya had a partial deletion of chromosome 22q11, and from there, once we got the diagnosis, then we did the workup for other things. So we looked at her heart and found out that she had some holes in her heart that we're following, but she doesn't need surgery for them so far. Another common abnormality is a velopharyngeal insufficiency, which is in the family of cleft palate, and a lot of these kids will have a hard time making sounds because they can't close the air passage between their nose and their throat, if you will, and so. And also Roy had some speech difficulties as well, but she is in preschool now, is assimilating very nicely. She is talking. She does do speech therapy once a week. She does physical therapy, occupational therapy as well. She goes to preschool 3 days a week, and then goes to special needs school, which has been wonderful as well, once a week. And she's really coming along and enjoying life.
That's great. And tell me about the annual event that we have here in the Minneapolis-St. Paul area.
So we've got a wonderful support group here in the Twin Cities group, and there's an annual international event called 22Q at the Zoo, and you can visit our Facebook page as well for 22Q in Minnesota. We make T-shirts here and have fun activities, and a lot of times have a speaker, usually someone with 22Q that's a little bit older that comes in and speaks, and just a great place for people to get together, one, raise awareness for the disease, and two, show support for each other and get to know one another.
What has you excited for year 13, year 23, where this discipline will be?
I think there's so much research and innovation. One of the reasons I think I and a lot of other neurosurgeons became neurosurgeons is to treat brain tumors, and so there are certainly some areas of brain tumor treatment or brain cancer treatment that we've really come a long way, and patients are living longer and healthier lives after diagnosis. And there are some areas where we really haven't made a huge strides, and I really feel like we as human beings we've overcome so much and are so innovative that the future lies in treating these brain tumors without hopefully even needing surgery. And so hopefully we can eradicate some of these diseases that we now have to treat with a craniotomy.
Do you have any work with concussions that you do?
Absolutely. So we have in our neurosurgery department, we have a very large concussion clinic, which, as you can imagine, is much busier during hockey and football season and less busy during the off season. But our concussion is run mainly by our nurse practitioners who are very well versed and experienced on the latest literature, information, and treatment options for concussion. And Dr. Petronio and myself oversee. Dr. Petronio, myself, and Dr. Rob Das, our neuropsychologist, oversee the concussion clinic. Kids and parents, you should wear a helmet when riding your bike, when skiing, when sledding. Protect your brain.
Dr. Kebriaei, thank you very much.
Thanks for having me.